Hi, my name's Chelsea. We're going to go over an erector spinae block today and then landmarks for an IJ. So my patient here is a 33-year-old female. She's coming in for a VATS procedure for a right lower lobectomy. So we are going to do the erector spinae block. You can use this block for anything in the chest wall, rib fractures, trauma. We're going to do the thoracic approach, so it should cover our back and our front thoracic area. Benefits of this procedure: it's going to decrease our pain post-op, hopefully have a quicker discharge to home, decrease the amount of MAC and opioids that we need to use, so decrease post-op nausea and vomiting. Overall, make it a better recovery. Some risks with any of our blocks: we have infection, bleeding, local anesthetic system toxicity. This is a high volume block, but we are still under our threshold, so we should be good. And then because we are going to the posterior of the lung, there is a pleural risk, but we shouldn't anticipate that with our ultrasound. I've gone over these with the patient before surgery and she consented. I did an exam. Everything looked good neuromuscular wise on her back. Everything was good for general anesthesia. Airway was easy airway. I looked over her labs. Coagulation, no issues. INR was less than 1.5. She's not taking any meds that we needed to stop beforehand. Alternatives: we could do this without our regional anesthesia and just do general, or we could do a thoracic epidural or spinal or a CSE. So because it's a but it's a plain block, you can do this when the patient is already asleep. So we will have her already induced positioning. You can have them prone like we have our patient right now. You can also do it lateral or sitting if they are awake, if you do it before induction. So this is a sterile procedure. We would sterilely prep our patient. We would be sterile. We'd have a probe cover. We'd have all of our other equipment. We have our syringes full of our medication. For this one, we're going to do 0.25% bupivacaine or ropivacaine, and we're going to do 20 to 30 mils. We would have a stopcock, NS, preservative-free NS, our needle, and our lube and ultrasound, everything. So we are going to go over this block. So landmarks, you want to be at about the T4 level. So the bottom of the scapula is T7, the spine is about T3, and then you could use the prominence, which is C7, to count down on the spine, and your probe is going to be parallel to that. So we're going to go about right here. And we would be sterile with our probe cover. Orient here. So you're going to go lateral to the spine, and you're going to find some ribs. So right here we can see a rib. It's more rounded, so we know it's rib, and we're out lateral. So we're going to slide more medial until we get a more flat surface. So let's see. Here's our ribs. So there we have flattening out, which would be our transverse process. So transverse process, the ribs would be below that, that's where they meet. This muscle would be your erector spinae muscle group. And then depending on where you are in the back, it's going to be trapezius, and then sometimes you can see rhomboids, and then subcutaneous tissue. So here you're going to do a needle approach cephalad to caudad. So you would come in plane, come from the top of your probe, and as you're coming in, your needle would be coming from over here, and what you're aiming for is the top of the transverse process. So you're gonna go to the white, and you can hit the bone as like a backstop, and then when you inject, you're gonna inject about 5 mils at a time of the 0.25% bupivacaine, and you're gonna see spread between the erector spinae muscles and the transverse process. And then you'll get an accordion effect if you watch this as the local anesthetic spreads in the plane. So again, it's a high volume block, so 20 to 30 mils to make sure you get adequate analgesia. And then we are going to have Marion flip over. Obviously, it's a different procedure. For a central line, we're going to look at her IJ. And again, this is a sterile procedure. For both of these procedures, your patient would be hooked up to all the monitors. So obviously, before we induced, we would have had her hooked up to a pulse ox, blood pressure cord, EKG, just so that we would know if we did have any of those risks, like LAST or intravascular injection. So going on IJ, so for landmarks for this, you're gonna look for the sternocleidomastoid. You're gonna go to the 2 heads, which you can see by putting your hand on the patient's head and having them push against you. It creates a triangle. And your landmarks, you want to either, for your needle placement, you're going to go in the triangle or posterior to the sternocleidomastoid. So we're going to look. This one you want to have light pressure because you don't want to occlude that vein that you're trying to go for. So we'll just decrease a little, give us a better picture. So right there you can see her vein and artery. So carotid artery and IJ and sternocleidomastoid. So for this, when you're doing it, you want to center that vein on the screen, and then you're going to come in an out of plane view with your needle. So you're going to come, because it's centered with the screen, you're going to go in the middle of your probe. You're going to come obviously superior to inferior. You're going to come down, and as you're coming in, you would see tenting on that IJ. So your needle would be pushing on the IJ, and as it pierces through, the tenting goes away. So then you know you're in the spot. You would aspirate back, make sure you have blood return. Then if you have good blood return, you'd thread your wire, and then once you have your wire in place, you can put your probe back on and find your IJ, and then you can rotate the probe to get in plain view, so that artery is on the bottom, the vein is on the top, and you would see the silver wire going through, and then you would know you're in the right place. And that is an IJ and erector spinae.